Here, I was just asking questions and I'm just doing my little nursing assessment where we're like, okay, let me listen to your lungs. And then she just like goes limp. I'm just like, help me. And so I pressed the cold blue button and it was like, all the people, you become very popular when you press the cold blue button. And it's everybody in there, doctor, nurses, everybody, RT, labs, they're there. And we got the patient back. But that was a very overwhelming, like, oh, this is real nursing.
Hey there. Ever wonder what it's really like to go from late night study sessions to actual life and death moments on the hospital floor? Well, on today's episode of Academic Survival, we're following Mikaela, a nurse, survivor, and advocate, as she shares her winding journey through college pivots, on-the-job reality checks, and what happens when you're the one in the hospital bed. Whether you dream of scrubs or just want to hear how someone survives the ultimate test, this episode is packed with honesty, resilience, and some real survival wisdom. Let's jump in. This is the Academic Survival Podcast, and I'm your host, Dr. Shandra McDonald. Statistics show that approximately 40% of students drop out of college every year. In fact, nearly 30% drop out their first year. Well, I am on a mission to improve these stats. Welcome to the Academic Survival Podcast. Today I have with me Mikaela, and she is a nurse. We're just going to jump right in and start from her academic foundation. So Mikaela, welcome to the Academic Survival Podcast.
Thank you. Thank you for having me.
I'm excited to have you. You are the second nurse that I have had. And what I found was that a lot of listeners are interested in what you nurses have to say. So
Really?
I'm excited to have another nurse on the program. But before we jump into your career, let's start off with college. What college did you attend and where is it located?
So my undergrad college is at the University of California, Davis. It is way up north, so about 400 miles, 6 hours north of here and near Sacramento. I would say like 20 minutes away from Sacramento.
From here, where's here?
Los Angeles.
What degree did you earn?
So I earned a human development degree, African American studies.
Well, that doesn't sound like anything in the medical field now, does it?
It's one of those degrees that is palatable to several different avenues. My good friend, she is an occupational therapist. She has this degree as well. You can go into urban development with this degree, psychology with this degree. A lot of nurses came out of this degree, and even some degrees. A lot of the pre-meds were, the biology degrees. But if you really wanted to be marketable on the human front of things, the very personable approach of things, human development was a good degree because it had a lot of these social, psychological, even biology aspects of what it means to be a human across the lifespan.
That's good.
Yeah.
That's good. Is that a route that you would recommend?
Actually, yeah, if you're going to go into something like nursing, because a lot of your nursing curriculum will be lifespan curriculum, which is psychological, your medicines, pharmacology, the way you treat patients, and the different age groups like, pediatrics and even the geriatric lifespan, you're going to follow that in nursing. And so having this degree was kind of actually very, very, very helpful because we went to the psychology of things, even social economic view of things. So sociology, psychology, mathematics, biology, it's all of that in one, but just more human focused, what we experience as humans.
Got it. Did you know all along that you wanted to be a nurse?
No, ma'am.
When you chose that degree, then what was your thinking?
So I initially went into Davis under the path of animal science. I wanted to be a veterinarian.
Ah, okay.
Yeah, it was a pivot. So I knew applying to college, I wanted to be a veterinarian. So I applied to Cornell, I applied to Davis, all the places that had vet med in their graduate programs. So my first year, I went into Davis as an animal science major, and that's the track that most veterinarians take when you go to Davis. And I was kicked by a cow, and that was the end of that. So
Kicked by a cow?
I sure was. And I said, you know what? They're better as burgers. So I'm just not.
Oh my my gosh, maybe they knew. And I was like, nah,
and you know,
she eats my kind.
and it's interesting that the animal science degree at the undergraduate level really has not much to do with like vet med. You learn more about the husbandry and the farm to plate aspect of agriculture. And so we had a lot of that domestic animal, cows, horses, sheep type of curriculum. So that's not really what I set out to do. And that would kind of change how I looked at what I wanted to do in life. Like, do I want to continue to do or be in the field of animals when there's lots of risk involved, like being kicked?
Yes.
And then also I looked at my work-life balance. I was like, you know what? I feel like you spend a lot of time and money to be a veterinarian, and there's not a lot of payoff, in my opinion. Other people might feel differently, but so I pivoted after that. So I'm like, well, I don't know if I want to do animal science anymore. What degree would be kind of a catch-all for potential things that I might want to do? Because I do have interest in health-related fields anyway. I've
Mhm.
dabbled with the idea of being like a PA or a doctor or something like that. Nurse was never on that front though. I always thought
Okay.
on the other side of things, like I want to be a doctor. If I'm going to be anything, it's going to have the title doctor or physician assistant or whatever. And then I continued and I graduated and I ended up becoming an EMT for a little while just to try and see what
Mm.
healthcare field can I get into? Like, what can I see while being an EMT? And so that would dictate the route that I chose because I have a bachelor's degree. Now it's time to do the elevated degree, the graduate degree. So I didn't know whether that was MD, physician assistant. I didn't really know what a nurse practitioner really was at the time.
Mhm.
So when I was in, some of these, places and, on the field and in the hospital, because we did, hospital transportation too, I got to talk to a lot of people, know a lot of people, kind of see and understand certain things. And so that dictated maybe nursing is not a bad route. And so in asking questions to people I knew, I found that maybe a nurse practitioner degree would be the best degree for me. But I
Okay.
would need to be a nurse to do that.
Okay. And so, for those who may not know, can you tell us what an EMT does?
So an EMT is an emergency medical technician. So it's the people you see that when you call 911, usually there's a basic life support specialist, which is that EMT, and then there's the paramedic, who is that more advanced life support. They also always work together in the ambulance together. So it's those crews you see that respond to traffic accidents, or you call 911 for a health emergency, or the people you see on the ambulance that are transporting from a hospital to home or a hospital to hospital. They're those people that are in the ambulance.
At some point, you end up in nursing school?
Yeah, so I was in a health internship. It was called Health Career Connections right after college, and immediately started that in June. And over the summer, I worked for a clinic called the South Central Family Health Center, and I was an intern, but a program coordinator. And my job was to try and find ways to engage the community around us into participating in programs that increase health outcomes. So, like my initiative that I took on was the HPV vaccine. I wanted to get the community around that was Black and brown, mostly brown, underserved, possibly undocumented, low resource, those communities to be more aware of what HPV is and the vaccines that are preventative for that, and to, increase our numbers in getting those vaccines that are helpful. So in that field, I understood that, what, I like healthcare and I want to be the person on the front. And so from there, I said, well, let me pay and get my EMT license. It's like a 3-month program or whatever. Did that. And while I was there, I realized in looking at all these hospitals, treating patients and going back and forth and talking to paramedics, because we also had nurses on our ambulances too. They're critical care transport nurses. So I, picked their brain a little bit. And I found that nursing gives the best all around work life balance. With doctors, you spend a lot of money and time to be a doctor in the initial front. So that's the 4 years of undergrad, the 4 years of medical school, and then you have residency. And if you want to specialize in anything else, there's years on top of that. So it could take 20 years to be a fully fledged, experienced person in medicine. So with that, I'm like, I don't want to do that. And then I still didn't really quite understand what a nurse practitioner or a PA was. But the nurses were like, when you become a nurse, it's you make good money, you do your job as 312s or 410s. It's a nice flexible schedule. You can have, 7 days on and have 10 days off. And, that appealed to me. And I really like the idea of work-life balance. So because I've always envisioned myself being a family person. So that's how I was like, you know what? I'm gonna apply to nursing school. And that's where that went.
Yay! And so here you are. So I hear a lot about clinicals. What exactly is that for those who may not know?
Clinicals are the clinic rotations that nursing students do while in nursing school. So you hear that you're doing your rotations or whatever. You go to that facility, that hospital, that ER, whatever section of nursing study you're doing. So like if we're working on our ER to this month, or we're working on our med surg medicine nursing, sorry, or we're working on our mental health segment, we're going to those actual clinical scenarios. So in the hospital or that mental health facility or that ER, and a lot, even public health scenarios. I did a public health rotation, so we went to a public health department, we went to other public health spheres, and we were shadowing other nurses while they do their shift. And they teach us stuff. You learn how to do IVs, you learn how to place Foley's. A lot of your skills are hands-on learned in those clinical rotations. So you have your classes, we have our mental health nursing classes, and then along with that class, you'll go once or twice a week to that hospital that you partner with, and you do a rotation with the nurse that you're paired with, and you help them do their shift, and they let you do meds and IVs and all that jazz.
So, looking back at your clinicals, what was your biggest moment of feeling overwhelmed?
Ooh, I have to say there was a time. So like I said, the clinicals, they match the class you're taking at the time. So I was in my med surge clinical, and we were finishing that up, but there weren't too many nurses available for me to shadow. So they paired me with somebody on a step down unit, which is like between intensive care unit, the ICU, and a normal, like, med surge, which is medical surgical, somebody who is at a basic level of sick, for quote unquote basic level of sick. They're not super super sick where they need one-to-one monitoring by a nurse, but they are sick enough to be observed in the hospital. And so that's the most basic,
The
like,
lowest
hospital
level of
admission,
entry into the.
lowest level of care, like, of entry when it comes to the acuity levels. But step down is in the middle of that. And so these patients aren't quite, walkie talkie, basic level of care, and they're not quite ICU. So I got paired with this person, and this is a great nurse, and he was phenomenal. But he was strict, he was stern. And I got overwhelmed because this patient, I kind of had a sense for what nursing was back then, before I even was a nurse yet. But it was like, I don't think this patient should be in step down. They need to be in ICU. Like, this patient had a lot going on. It was an older woman, and I was like, okay, I don't know if she's doing well. I just had a sixth sense about it. But her vital signs were saying different things. Like, they looked in the realm of what should be normal for a sick patient at that time, what she's presenting with. So it wasn't like she was crashing, but she also was a little sick, and you could tell via her vital signs, but it wasn't worrisome. But it just, something didn't wasn't right with the patient, and she ended up coding, meaning she ended up going into cardiac arrest or some type of respiratory arrest. I couldn't remember which. So I pressed the code blue button because I'm like, I'm just in here. I was just asking questions, and I'm just doing my little nursing assessment where we're like, okay, let me listen to your lungs. And then she just like goes limp. I'm just like, help me. And so I pressed the code blue button, and it was like, all the people, you become very popular when you press the cold blue button, and it's everybody in there, doctor, nurses, everybody, RT, labs, they're there, and we got the patient back. But that was a very overwhelming, like, oh, this is real nursing. Like, this is like, it was a very much a reality check, and it was very overwhelming for the time. And this is coming from somebody who was, during our simulations and during our skills training outside of the clinicals and at the school, we're doing, like, pretend training basically. I'm always the first to volunteer. So coming from somebody who's like confident enough to be the first to volunteer all the time, to now being like, wait, I pressed the code blue button, and now they're having me do stuff like, can you take this and hold this? I'm just like, I don't want to hold nothing. I don't know anything. I'm very much, I want to step back and just let y'all do your thing.
This is like real, like not a simulation here.
No, this is not a simulation. This is not skills lab. This is real life nurses doing what nurses do.
But you came back. So tell me about that. Like that didn't frighten you away. That didn't.
No, because I'm coming from the background of emergency medical trans or technician, like, EMT is very like 911, go go go, patient. I've done stuff as an EMT where the patient collapsed in the back of my ambulance, and we're almost to the hospital. It was a scheduled transport to their doctor's appointment, and the patient basically went limp in the back of the ambulance, and I'm like, hello, like hello, and I'm like checking pulse, and like it's very faint, and then I can't feel it anymore. I'm just like, oh, we need to upgrade. So I'm tapping the window, upgrade to code 3, which means like get to the hospital now, like lights and sirens. And so I'm doing chest compressions on this patient because I don't feel a pulse. And so I've been in situations where I'm on top of the gurney, on top of this patient, being rolled with the patient on top of this patient, doing chest compressions into the ER. So I've come from that background, but with nursing, because emergency medical technician is very like, my job is to try and keep the patient alive, or at least their heart pumping enough so that the nursing and the doctors can take over and do the actual interventions. I wasn't a paramedic, so I can't do IVs or meds or whatever. I just do chest compressions. And so that's what I was doing. But now as a nurse, you do the interventions. Like the doctor says, order this, you do the orders. So I'm like, this is a whole different realm of like, okay, now there's actual stuff to do. And I don't like not knowing what to do. And in that moment, I did not know what to do but press the cold blue
Right,
button.
right, right.
But I came back because I'm like, okay, that was overwhelming, but that means there's something for me to learn. And I was like, okay, now that I know how it goes down, I feel better prepared to know what I need to do.
What would you say would be the one thing that kept you from quitting?
I think it's a couple things. It's I feel like it's in my nature to be very to persevere and to just get through because I've always had goal oriented mindset. I've always knew I wanted to get a graduate degree. I've always known I wanted to do this and this and this. So I just have a persistent mindset. So whether it was tough for me or not, I wouldn't have quit just because I don't have that type of mindset. But there were times where it's just like, dang, am I as smart as I thought I was? Or do I have some sort of imposter syndrome? Because like I thought I crushed that exam. I thought I studied what I needed to study, and kind of, didn't do as well. In nursing school, you can't get less than an 85. That's a fail. So me getting like an 87 is just like, I almost failed. Like, so my willingness to always just like stick it through kind of kept me. And knowing that I had to keep it in the back of my head. I am smart. This is just
If you
hard.
just don't quit, you will get to the end.
Right. It's literally one day at a time, progress, not perfection, one foot in front of the other, one day like it's step by step.
So I've heard of this concept called nurses eating their own. Can you tell me a little bit about that? And did you experience that?
Yes, I have a couple times.
So first, share what it is.
So, nurses eating their young is this concept that this type of nurse that's very rude to you, that, doesn't really want to teach you things. It's the idea that you as a new grad or a nursing student should already know things, and you come into this field and they don't want to teach you things, they're rude to you. It's just not a welcoming environment, and they're just hard on you for no particular reason. They're not, I don't think that they're trying to mold you into anything. They're not trying to, give you tough love. It's just this idea that nurses are not nice to the new people, the new kids, or the new, nursing students. And it can be shown in more ways, like in a multitude of ways, really. It can be shown in not accepting a nursing student, like blazingly, like in their face, like, I don't want nursing students today. I don't feel like teaching. Like it can be rude that way, especially when you are a nurse and you're a new grad or you're new to that unit. It could be shown in them not helping you when you actually do need help on the unit when something's going down. It could look like throwing you under the bus. It's basically toxic work culture, but to the newbies. And sometimes you're not a newbie, you're just new there. It's always the older ones. And it's this idea that sometimes nurses are jaded. The longer they stay in nursing, you get more jaded and jaded. And so therefore, caring for people, including your coworkers, it gets lost.
Wow. What impact does that have on the patient?
Patients see it because I've had circumstance where the nurse was being like rude to one of us, like because sometimes there's like a couple nursing students in there with the patient and the nurse, and when the nurse would leave and we're in there doing what we're supposed to do or whatever, like or just ask our questions and our assessments. Sometimes the patients are like, "Are you okay?" And they see it, and it's just like, "Why aren't you nice to people?" And I feel like that impacts patient satisfaction for sure. 'Cause if you're rude to this young 20-something-year-old, how are you to patients who are, underserved, underprivileged, lack resources, yada yada.
Yeah, no one necessarily wants to be served by the mean nurse, right? I just saw you eat your coworker. Now you're gonna turn around and smile at me? I don't know. I don't know if I should trust it. So then what is a hot take you have about nursing that they don't teach you in the textbooks?
Ooh. think a hot take in nursing that they don't teach in the textbooks, it has to be that nursing is not the same as the textbooks. Your real life nursing care, how you are as a nurse, the job that you do is not the textbook at all. You learn in the textbook, you learn all this theory stuff. And the theory is important because it dictates how we do our nursing. It dictates our policies in hospitals, and of course it dictates the knowledge that you have going into the being a nurse and taking the test to be a nurse. However, it is not the same. You get on the floor and you're like, "Oh, well, I learned that when I do a Foley, I set it up this way. I make sure I gel my hands, which is always important. Wash my hands and I do it this way. And this is one, two, three, four, five. This is the steps and this is how it goes." That's not how it is. In many situations, you are not performing in the way that the textbook says should perform. And that could be a good thing and a bad thing because now we're not following a certain criteria, or in cases like COVID, all of that was out the window. Like real life nursing is not the same as textbook nursing at all. And it's a common hot take, but it's my biggest hot take. It really is not the same.
COVID was probably significantly different from the textbook.
I was there and I'm not going back, I tell you that.
So there's a lot of pressure on new grads to do med surg. I heard you mention a lot about med surg before specializing. What path did you take?
So you'll hear it, and that's another hot take, really. Once you graduate from nursing school and you apply for your nursing job, you should always go and be a med surg nurse first before you go into your specializations like labor and delivery or ICU and things like that. That's the traditional way that a lot of older nurses went about their nursing careers, and they feel like med surg is a rite of passage. And it's not just older nurses. Some people do feel like that med surg is, in my personal opinion, if you know there's a specialty that you want to go into, just go straight into that specialty because med surg is not for everyone because you have 4 to 5 patients at a time, and these patients are walkie-talkie. These patients, meaning that they're pretty much okay, they just need observation. Or these patients, they ask a lot, they have family members. It's just a lot for some type of nurses. Some people want to do just one-to-one ICU patients. Some people want to see, help, deliver babies in LND, and that's just 2 patients at a time, mother and baby. So I'm a firm believer that if you know what you want to do and you're passionate about it, go straight into that because they have new grad programs that help you transition into that specialty. So I would aim for that rather than a basic, med surge. Because it's also the idea that some nurses feel that you'll lose some skills or you won't learn certain skills. But if I'm never going to go into that specialty, there's no real need for me to be an expert in that skill. I'm very hyper focused. If you know what it is, just go into what you know. And you can always pivot because nursing is a job of 1,001, 1,000,001 jobs. So you can always pivot and do something else if you feel like you need to. But it's absolutely not necessary to go to med surg. It's not for everybody.
It would seem to me that the benefit of going into like specializing rather than going into med surg, the benefit of going into that first would be that you get to hone that skill longer. So you get to the level of being an expert quicker
Mm-hmm.
than if you went the med surg route.
Yeah. And to that, that's a good point. And that's true for a lot, but a lot of the same skills in the basics of nursing are in all parts of nursing. So when you go to the ED, you learn how to do or you should know, but like you learn more. They teach you more when you first start. So you'll learn how to do an IV. You'll learn how to draw these labs. You'll learn how to think like an ER nurse. You'll learn how to do a Foley. That's another field of nursing that can teach you things. Same thing with ICU. You'll learn how to do all the ICU stuff. IV, oh, you don't really do the ICU, but because they already come with the IV, they've already transitioned to ICU. But you will learn the Foleys. You'll learn how to do an NG tube. You'll learn the things needed for intubation should that happen in the ICU. So there's skills to be had across nursing in every field, but it can be quite daunting and stressful for somebody to start in somewhere like med surg when they're not meant to be there. Like I started in the urgent care ER, and because of COVID, they had me in the ICU, and I was there for quite a while. And then I transitioned to surgical nursing. So I would have never survived in med surg. I'm not that kind of nurse.
So did you ever experience being a travel nurse?
I did for a little while, probably about 3 years.
Oh, that's long enough for you to know if you liked it or not.
It is definitely, it's one of those things. It's special. It's a specialized thing. It's not for everybody. However, this goes back to your last question. Nurses who are a travel nurse, they do need to have some type of experience before they start traveling. Because basically, essentially what a travel nurse is you are being picked up by agencies to and placed in different hospitals across the nation, or even local traveler. I've done local travel nurse too in just the local LA area. I've gone out to Oregon, things like that, a bunch of states. But these agencies send you to places that have openings, and you're supposed to basically hit the ground running. Only thing you're learning is the charting system, but you should be able to stand your job at that new facility. So the basics of nursing you should have. So you should have at least, I say, 2 years of experience before you go to a travel nurse job. But it is a lovely job. I like traveling, and that's back to the other question. You see a lot of nurses eating their young on the travel units. They're a lot meaner on the travel units.
Let me tell you, my mother was in the hospital about 3 years ago, and she was there for 3 weeks.
Mm-hmm.
Felt like longer because she wasn't supposed to be in there at
Yeah.
all. She had received a pacemaker. That surgery went well,
Mm-hmm.
but for some reason, her sodium level was too low, like dangerously low. So they wouldn't release her. I got to experience various travel nurses, and I can tell you by far the travel nurses were much nicer. They were more kind, and to the point where I started saying, "You're a travel nurse, aren't you?" What was that about? Why were they so much nicer than the other nurses? Your opinion.
In my opinion, it's because the other nurses are probably mean to them. Because there's this stigma going around, and not so much before COVID, but so much during COVID, because a lot of the travel nurses make much more than the staff nurses do. And that's because, they get stipend, and they get, there's an incentive to come from your hometown and go to this rural area or wherever and be a nurse there, where they may not have great staffing, they may have, higher risk population. And so they're incentivized, these travel nurses, to go there, so they get paid more. And so a lot of staff nurses from that local area sometimes may have a bias against that and don't want the travel nurses there. So sometimes they're meaner to the travel nurses because they make more. Like, how are we doing the same job and you're making more? Maybe how come my hospital is paying you more and not paying us? And that type of thing. So that can bleed into how you create relationships in your workspace. And if those travel nurses are typically nicer, one, because they're used to meeting new people and like to meet new people because they're traveling and they're meeting new people all the time. And a lot of times, especially during COVID, these travel nurses they know their stuff. They're coming from places and have experience where they know their stuff. And so there's a confidence about them too sometimes. People who travel are just very airy people, and they love to experience, and they're very outgoing. And that's what I've noticed when I come across travelers. And I actually appreciate travelers. I mean, that's what made me want to be a nurse, because they come from different walks of life and different experiences, and they usually know their stuff. Now, there are horror stories where the travelers don't know their stuff, and that's another thing. But I typically find that travel nurses are pretty good employees.
I think you hit on something really key is that if they like to travel, they tend to like to meet new people, and that's exactly
Mm-hmm.
what they're doing, is meeting new people. Are there any like pros, cons of being the travel nurse that you can share?
The pros of travel nursing is there is a financial incentive. You do get paid more. And that's not just because the hourly rate might be higher than a staff nurse, it's because of the stipends too. So if you can hack the system, you can hack it. Well, a lot of travel nurses will live, like, say, in Georgia, and then they still have their staff job, and then they'll take a short contract here and then make all the money there. They have somebody who they can live with here, and so they can, rake in all that money. So it's a financial incentive. Another pro is you get to meet a lot of people. A lot of the travel nurses that I have, a lot of my friends I still keep up with via text and social media, they were travel nurses, and I see them all around the globe. When I say around the globe, like my travel nurse friends, she has worked in different states like, Texas, Florida. She's worked in some of the Caribbean islands. She's worked in Hawaii. You get to work, do your 312s in a hospital, but then the rest of the week you're chilling on the beach in Hawaii. So if you like to travel, and a lot of people come from the East Coast and the South to California for that very reason. A good handful of my close nursing friends were travel nurses that end up staying. So
Oh,
yeah, so there's that travel aspect, and they're definitely outgoing people. Another pro is you learn a lot. The way hospitals do things. Like, I've worked at the Children's Hospital of Orange County. I've worked at a rural hospital in Roseburg, Oregon. I've worked at local places, local ambulatory surgery places here in Los Angeles, endoscopy places, colonoscopy places, cataract places. So you learn a lot about how different hospitals maneuver, what their policies are like. And this is from a clinical quality and hospital administration realm, because that's where I work currently. But I learned a lot about different hospital administrations, different types of QI projects, quality improvement projects, how hospitals do things, what their policies are like, what the way I do things at my current job as a floor nurse was different how the children's hospital did it, different electronic health systems. You become more knowledgeable. And then just the way nursing is, how you can do, like, I've learned lots of little tips and tricks that, have helped me in but the cons are sometimes people are mean to you. There is a lot of meanness, and that just goes back to nursing eating their young, or just the sometimes the jadedness of nursing. So you do have difficulties there. If you really like a place, or you like a people or whatever, you are just on to the next or whatever. And so sometimes it can be hard to get rooted somewhere when you like it, because they only had the budget for a traveler. And a lot of times they do open up permanent positions, and travelers do end up getting those, but sometimes it's just that's what it is, and you have to move on. That's unfortunate.
Mm.
Sometimes as a traveler, you can sign up, say, for a crisis contract. I remember a couple years ago, while I was ending my current contract, there was a Minnesota hospital that was under crisis. Like, they didn't have enough staff. And so they were calling for nurses to go ship out there. And the contract ended before I could even get there. They got the flight and things like that. And once I stepped foot there, oh, the crisis ended. Like, the contract was over.
Oh,
So
wow.
there's risk involved with that. I mean, they help you out to get you to the next thing, because a lot of these agencies are like, on to the next, on to the next. They're already communicating with you weeks before your contract is over to get you to the next. So they could pivot well as well. So it's not like you're just just left out to your own devices. But there's that. And then sometimes these hospitals will try, and these managers will have you do things that are unsafe for patient care. Try to give you more patients, or too many unstable patients at the same time. And you kind of get the short end of the stick a little bit as a traveler, because, quote unquote, you get paid more. So there are a couple cons to being a traveler. You really have to, know your stuff, be able to stand on your own, and be firm in that. And then you got to be flexible.
So far we've talked about your nursing background, we've talked about your educational background, how you pivoted into nursing, and then what nursing has been like as far as the various careers. Now I want to ask you, have you ever been a patient? And if so, how was that experience?
So I have definitely been a nurse, and I've definitely been a patient a couple times. When I was 23, I had what's called a pulmonary embolism, and that is a blood clot in your lung. And so that was surprising. So that did hospitalize me right as I started nursing school. I was literally 2 weeks into nursing school, and that hit me. So I was hospitalized for that. And of course, I had great administration, and they were supportive, and I was able to get back to my classes literally, in due time. And so I finished on time. So that was my first, instance in being a real patient. And then recently, I just had my son, TJ. He's 8 months old now. So I had him May 9th. And throughout my pregnancy, I had experienced certain symptoms that what we now know as, preeclampsia. And preeclampsia is basically a condition where you experience elevated blood pressures, protein in your urine, certain symptoms like, headache, blurry vision, and things like that. There's other major symptoms too, but all that to say, that's leading up to what's called eclampsia, which is now at risk for seizures and things. Your blood pressure is so elevated, you have so much protein in the urine, so much protein in the body, and now you're in seizure territory based off of that elevated blood pressures and whatnot. So I didn't get there, but I had preeclampsia, and that culminated into my delivery. And I had the emergency C-section at 34 weeks. And upon the C-section, the baby was fine, and he was beautiful. He was 6.5 pounds. But immediately during the procedure and after, I developed what's called ARDS, which is basically acute respiratory dysfunction syndrome. And that was basically, it's an overarching term for lung failure, respiratory failure. And that was
Wow.
caused by flash pulmonary edema. And that just means that fluid had filled my lungs, and it made my lungs incapable of performing its function of exchanging oxygen and delivering oxygen into the bloodstream to the organs that need it. So I said all that to say the preeclampsia that I experienced came with swelling. So I was swollen everywhere. I started pregnancy at 200 pounds, and I developed about a month before I delivered, so about months 5 and 6. I delivered at 7 months. I put on over 30 pounds of fluid, and that was part of the preeclampsia, that fluid accumulation. And all of that fluid that was on my body during the C-section, the fluid rushed. It's called third spacing, so it comes out of the cells and rushes into a space and called, like the lungs or the heart. For my case, it was the lungs, and it made my lungs incapable of doing what it needed to do. So immediately after the C-section, they can tell on the vital signs and how I was doing that I wasn't doing okay. I wasn't breathing well. My oxygen saturation was not appropriate. It was in dangerous levels, and so I was placed on what's called BiPAP. If anybody knows what a CPAP machine is, when you go to sleep, it like forces air into your lungs so that you are a better sleeper at night. Well, a BiPAP is similar. It just forces air into your lungs so that you're able to breathe. And that didn't work. And so they immediately, like within hours, they were like, let's intubate. And so I was intubated and sedated. I was basically out for a little while. So that's I was put in a medically induced coma. I was paralyzed via, that's what,
This is
yeah, it was a lot. And from there, that wasn't helping. So intubation, all that is directly giving you oxygen and airflow into your lungs to be turned over and dispensed into your body, right? So all your organs. I was experiencing kidney failure from the medications I was receiving. I was restless, so they had to actually paralyze me. That was funny. Apparently, I was not a good and I don't remember any of this, by the way. I was so oxygen starved that I don't have a recollection. This is what I'm reading in my own documents and what I'm being told by my family and my physicians and stuff. So I even after the intubation, it wasn't working. And so they tried every trick in the book. They tried proning, which is when you flip a patient over on their stomach to, increase the oxygenation in the body. That wasn't working. They were giving me all kind of medications. My everything was still going like down, like it was going south. It wasn't getting any better. It was getting worse. And so one particular doctor, and also this is at the hospital I work at. So I've had my bosses and the doctors I knew were making personal phone calls to other hospitals to get me a machine called ECMO. And essentially, what ECMO is, it's basically a machine that works for heart failure and lung failure, one or the other or both. And it takes the oxygen or the blood out of your body through your femoral arteries in your legs or in your jugular, your carotid arteries. And it takes the blood and it circulates in a machine, giving the blood oxygen. And then it brings the oxygen back to the body so that it can be utilized and that you stay alive. And a lot of times, the people that go on this machine, they're experiencing some sort of major heart failure, major lung failure, or both, or whatever. And in 50% of cases, people who get on this machine are so far gone they perish, or the problem is so severe they perish, or just it's just not working for them.
Oh wow.
So I was placed on that machine. Like I had the baby Friday at 1:30. I was on that machine by the next day.
Oh, that was a really, really rapid decline.
Yeah, it was very, and to that I do say that my decline started probably before that, and I was having symptoms that I was complaining about that kind of weren't escalated or weren't appropriately addressed. And me, again, being a nurse, I'm understanding what these numbers mean. I'm understanding what needs to be done, but I had trust in my doctors and the experts that were caring for me that I was okay, and they were saying that I was okay. So if you say I'm okay, then I must be okay, right? So I wish I was a better advocate for myself in those moments because, my husband and my mom were all like, you don't look good. You don't look good. Even my bosses were like, you don't look good. Are you okay? Reach out to this person, reach out to this person. And I do. And they say I'm okay. And I'm like, okay, I guess I'm okay. I might be really swollen. I might be really tired, shortness of breath, all the things. I saw a cardiologist before. I was on a heart monitor for a while. They scheduled me a specific, it's called an echocardiogram. It's like an ultrasound for the heart to show its function. I never even made it to the echocardiogram. That was scheduled after the baby. Like the baby, I ended up having the baby before I could even get to that appointment. And so I had symptoms and I was complaining and they said I was okay. So then when I wasn't okay, I come into, and we end up having the baby and all this, precipitates and I have to get, ambulanced to a whole different hospital. I ended up at UCLA on ECMO because I started at Kaiser and I ended up at UCLA on their ECMO machine because our facility did not have an ECMO machine. And so I had to be shipped away and, put on this machine, to which I did get better. I finally woke up on Mother's Day. What a great first Mother's Day for me. My baby
Right.
was in the NICU, so I was separated from him for over a week. I didn't get to meet him for a week, and it was a hard time, but I had a very good recovery. I recovered quick. The ECMO definitely indeed worked for me, along with the prayers and beliefs of my family. I had to work to get off the machine because I woke up on the machine, but I was still on it. I was still intubated. And so I was awake intubated. So I had to, meet certain requirements to get off of the tube. And then I had to meet certain requirements to get off of the machine, the ECMO machine. So it definitely took some work while I was still in the hospital to even get off those machines and then go home. So being a nurse and a nurse and a patient at the same time, it's not fun because you know too much.
Yeah, I bet.
Because I was asking those IC nurses while intubated, they gave me a whiteboard to communicate with them, and I'm telling them on the whiteboard, what is my vitals? Where are my settings? I don't even know if they knew I was a nurse or not, but I wanted to know where I was as far as my health goes. Give it to me straight. I used to be an ICU nurse. Talk to me like an ICU nurse.
That's a lot. Thank you for sharing that. Where are you today?
There is something to be said about the first of all the postpartum experience and how that is life changing, and there's struggles in that, just being a new mom. But unfortunately, I did experience some PTSD regarding the situation, so am still affected there. I did develop a little bit of anxiety, and I'm not sure if that comes with the pregnancy and in postpartum, or if that you know culminated from my experience. But I recovered well, but I'm still on recovery.
The good thing is that you are here to talk about it.
I am.
Yeah,
It's
you
surreal.
made it. That was a lot. I mean, from a medically induced coma to being placed on this echo machine, having to be transported to a different location,
Hmm.
being separated from your son, like not really getting to meet him until
Yeah.
7 days later, you said?
Yeah, pretty much. It was, yeah, 7 days later. Nice.
All right, so let me just take a deep breath. How were you able to manage the double stress of being a professional in the medical field while navigating a high risk health situation?
Ooh, the double stress. I'm one of those people where I don't want to like play the card, like I don't want to play the I work here card, so act right, or let me, because I work here, I should get this consultation sooner or whatever. I want I don't want to, ruffle the feathers or disturb the water, that type of thing. And so it was kind of hard for me to balance the fact that I do work in the quality and safety space of healthcare. Like I'm no longer bedside anymore. I'm administrative in the quality and safety space. And then I have this high risk, medical situation during the time, my bosses are like, you need to talk to so and so, just, chat them on the teams and, talk to them. And I'm kind of timid to do it. Like, I don't want to like play that card, like, hey, I'm an employee, so help me. But I wish I
Yeah.
would have, because maybe I would have. And of course, I'm not trying to blame my own circumstance on myself by not, advocating, but I do wish I advocated a little bit more and had the confidence to say, hey, I'm having this problem. What do you think? Or kind of pushing at that, when they say, oh, you're okay, you're okay. And it did come to a point when I was, in delivery, because I labored for 3 days. That's another thing. In my delivery, where my epidural failed, and I was complaining that I was having more than just, the average amount of epidural pain, like, which just should be pressure. You shouldn't be experiencing a lot of pain because that's what the epidural is for. And I was having pain. And so I'm like, I don't know what to do. And I'm also delirious because preeclampsia patients get what's called magnesium. It's a drip, and it can make you feel delirious. It can make you feel like you're not yourself. So I wasn't in a space where I could advocate for myself in that moment. But I did have to tell the person who came to assess me, like, hey, I'm in a lot of pain. This is abnormal. And I know this is abnormal. And I need you to have some urgency in assessing this abnormal pain, because she was trying, like, well, I have things to do. I said, I really don't care about what you got to do. Don't have me call, because I still work there, and I used to be a recovery room nurse there. So, and I know a lot of the anesthesiologists, I know a lot of the surgeons. So I'm like, don't have me call the anesthesia on call number. I still know it, and I will still call it, because you cannot tell me that y'all are all busy. There is an anesthesiologist somewhere in this hospital that can assess a patient that is deteriorating. Don't have me play those cards. So, and I had to get stern in that moment, but that was also out of, being in pain. I'm tired. This is day 2, almost 3 of labor. So I wish I had that advocacy before, because I'm very nice and I just seem like, oh, it's okay. Like, yeah, I'm just not that person to be playing the cards, but I wish I did. And it's so funny because as a nurse, I would do that for other patients. So if the doctor said, oh no, you don't need, and I would go to the doctor like, no, they say their pain is this. Our policy dictates this. So I'm very advocate heavy when it comes to my patients. But when it comes to me, I don't want to be the angry black girl that's like, once that's crying and ranting raving over pain medication. I don't want to seem like I'm pain seeking, because that's a whole thing in healthcare. I'm trying not to ruffle the feathers and go through the channels, but I am not doing okay, and I feel like I should have advocated more for myself. But it's a double-edged sword. They say nurses are the worst patients. And we kind of are, either on the sphere of where I'm at, or we don't listen and don't seek the care.
Right, right. What is a real survival tip you wish you knew at age 18 before you ever step foot into a hospital?
Ooh. Survival tip. Given my most recent survival, actually, I do feel like at 18, have the confidence to say what you mean and mean what you say, to have the confidence to talk firmly and boldly
That's
about
good.
who I am and what I'm about. And I say this as a young 18, a older me looking to, like you said, a younger 18-year old me. Be bold, be confident, and you know your stuff, you're okay. You don't need to feel imposter syndrome. You know your stuff, you know who you are. And if you don't, find it out. Like, it really have the confidence about myself to step into the space and be confident about me and whatever I'm doing. Because that would have helped me in the situation that I was in 8 months ago. It's definitely helping me now, especially when I have to have crucial conversations with certain physicians and just the nature of my job in general. Or just back then in nursing school when, the mean nurses were talking to me a certain way, or doing certain things. I wish I would have had the confidence to either let it roll off my shoulder and pick my battle, or when to really like escalate something and really have that conversation. So confidence and boldness.
All right. So, as we toward the close of this conversation, you've just shared so much. I just have some real key things that I want to ask you. The first is, if you were designing a survival support system specifically for first year nursing students, what would it include?
If I had to design a survival support system, it would be like a chat GPT type of system, like some type of AI system that would be geared specifically towards the nursing students who are timid in some way, or like that confidence boost that they need, or like I'm afraid to ask this doctor this and this. How should I say it and what should I say? It would be a support that way, because I feel like a lot of the support that we get in nursing is the book side of things, it's the test, the office hours with the professor, but kind of the situational awareness, the emotional support, the colleague support that we might need in those clinical situations, or when we are a new grad. I feel like that's what I would support, and I do think that could also mean mentorship. There's plenty of mentorship programs, but sometimes you need something in that moment where it's just like, how do I say this? Like, is this too much? Or I'm feeling like this. You know, do I? I'm not feeling confident. What should I do? And I know a lot of nursing students, have struggled there.
That's an excellent idea. I'm going to talk to you about that afterward. Okay, so if you were teaching students the Michaela method to master nursing, what would be your top 3 rules?
Ooh, Michaela method to master nursing. Number one, this has carried me throughout my life. Be the first to volunteer, if you know it or not.
Okay.
Be the first of it. They love that. The nursing instructors and the skills lab people. When they're like, okay, so who wants to go first after they done did some miraculous whatever? So who wants to go first? And I would always be like, I'll do it. I don't know what I'm doing. And I would say it. I don't know what I'm doing, but I'll do it first. Like, I'll be the one, because that shows initiative. That shows that you're interested. And that just, it takes the sting of being now the second, third, and fourth. Okay, now they showed you how to do it. So be the first to
Mhm.
do all things. Two is to always have a script. Have a script for how you do everything. So when you meet in your clinicals, when you meet, your preceptor, or when you meet your patients or whatever, have a script for what you want to, say and how you want to come off. Because sometimes you're kind of like in the moment with things and you didn't think about like, oh, this is my first time meeting a patient, or my first time talking to a patient. and you kind of don't know what to say, or maybe you'll say the wrong thing, or something there's something you could have said better. Have a script for yourself, like, so my name is yada yada. It comes off confident, like, because a lot of I came in with EMT experience when I went to nursing school. A lot of my counterparts did not have any like healthcare, like, actual patient facing healthcare background. And so sometimes they were stuck on how to approach patients or approach nurses or approach doctors. I would say practice that, have a script for yourself, or practice it at home. So run through those questions, run through how you would approach somebody before. Number three probably would be, it's not that serious. Just
Okay.
just the idea, like, always, when you get to a hard point where you might feel like you didn't do something, correctly, or you were the first person to try something, or and it didn't come off the way that just didn't perform well in that like skills lab, or you didn't get that IV, or because a lot of these nurses are overachievers. So that's another aspect. So I'm just like, it's not that serious. Take a deep breath and let it roll off, because you'll have ample opportunity to do it again. Don't sweat the small stuff. It's not that serious. So just keep telling yourself, don't sweat the small stuff. It's not that serious. Have a mantra for yourself, or that's really what number three should be. Have a mantra for yourself. Whether if you are uptight about something, it's not that serious. I can try again next time. Or if you need a pep talk, I can do hard things. That's what I've been telling myself. I learned through social media. I can do hard things. I can do so. Have a mantra for yourself that keeps you focused and keeps you going. I do that every day with my son, with work, with all things in life. I can do hard things.
So, in what way are you specifically impacting the lives of others, be it your patients or colleagues or mentors? Like, what are you involved in?
So currently, my job right now is that I'm a quality and safety RN consultant. So my job is to review clinical scenarios where patient might have felt their care was subpar, or there was a scenario where we should investigate a circumstance like an unexpected return to the OR, or unexpected death of, or some type of gapping, or some type of, like in my situation, a higher acuity send out where there was something in the care that flagged the system. We should look into it just to make sure we're on our P's and Q's. So I review clinical scenarios that are like that. And we discuss how we could either improve if there is areas of improvement, or if we met standard, or how can we adjust the standard to be more comprehensive. And so in that's how I choose to give back, rather than being, because after my PTSD, I can't be on the floor anymore. But this is how I try to install change, because there is always somewhere we can improve. And when I see these cases of, for instance, I had a case where it was a unexpected return to the OR, and no fault to anybody. It just, the patient's, circumstance, just, it was what it was. And, she's doing all good in things, but there is a gap in how we communicated to each other. That didn't affect care, but I can see a point in where we can, improve this system so that we have a faster delivery, or we don't fall into an area where we had a poor outcome or anything. So I really like to look at systems and try to improve and make sure that we are on our P's and Q's as a hospital to provide the best care. And then patients feel like they have good care. Because again, in my own circumstance, I feel like there were gaps in my care. And so already being in the job that I have, there are areas in which I am being the change that I want to see, where I'm seeing the gaps. Let's identify that. Let's come up with a policy or some type of solution for this gap. Okay, that's great. I can see that we fell short here. How are we going to not fall short again? How do we hold people accountable for when they blatantly fall short? That's where I'm, giving to nursing as a whole.
What final piece of advice do you have for nursing students graduating this year who are terrified of their first real shift?
Nursing is so much different than when I was coming into being a nurse, because it's pre-COVID.
Mm.
COVID kind of messed everything up. So it looks different, and I recognize that nursing looks different. But the advice that I would have for new nurses coming in this year: take advantage of the resources of today's technology, meaning, the AI that we have, the advanced health charting systems, like just the technology, specifically like Chat GPT, Copilot, Gemini, all those things. I'm finding it's a good resource for when you're applying for jobs and being marketable. I would suggest that if there is a role that you want, run that role through ChatGPT. Let it give you the highlights of what it means to be this nurse, and then have ChatGPT tell you what characteristics that you can improve on to be marketable to that role. Because right now there's a huge job, like, I don't want to say freeze, but there's lots of quote unquote shortage in nursing, but there's not a lot of hiring either. So, and you want to be marketable, you want to be, you want to be the person that they pick. And that's part of getting your job. And I feel like that's something that's missed in nursing.
Mhm.
And everybody talks about when you get the job, but how do you get the job? So, try and really utilize the tools that you have, like ChatGPT, to really hone in on the things that you can improve on and things you can target when it comes to applying to these jobs.
So to close us out, I am going to do a quick fire round. Are you ready? Okay, the first question is, best item in your nursing bag?
My water.
Favorite on-the-go meal?
Protein bar.
Okay. And then in one word, what describes the feeling of your first 12-hour shift?
Tired. Tired. Feet hurt, all the things.
All right, there we have it. Water, protein bar, and tired. Mikaela, thank you so much for coming to the Academic Survival Podcast. It was a pleasure having you here and sharing your insight with those up and coming nurses.
Thank you. Thank you for having me. I very much enjoyed it.
That's it for today on Academic Survival. If you want to share your story on how you survived your freshman year of college, you can reach me at info@chandralmcdonald.com. We'll be back next week with more ways to survive your academic journey. Until then, happy studying.